Okay, so that's pretty much how the normal ECG waves and some of the basic abnormalities come about. So let's just use that as a basis to very quickly work through some abnormal ECG patterns. So just now we mentioned that when the electrical impulse travels from the atria down to the ventricles, it has to go through the AV node. And the AV node conducts more slowly than all the other portions of the conducting tissue of the heart because you need that delay to ensure that the atria finish contracting before the ventricles do. So even under normal circumstances, there is a PR interval, which is the gap in between contraction of atria and start of contraction of the ventricle. But sometimes there can be damage to the AV node and electricity flows through much slower. So that will give you a prolonged PR interval because there's slow movement. If for some reason you have some kind of extra pathway that allows electricity to move from atria to ventricle and bypass the AV node, you can have pre-excitation, and you would see that as a little bit of a transient rise over the where you should have a flat PR interval. And that's usually what you see in Wolff-Parkinson-White syndrome, which is probably beyond what you guys need to know right now, but I'm just kind of adding it in since it's here and it's not difficult to understand. Now, you've also heard about AV block, first degree, second degree. So AV block means there's literally a block. It's really difficult for the impulse to pass through. You can have a first degree, second degree block depending on how long it takes for the impulse to actually get past the block. Or if you have a complete heart block, the AV block is totally not conducting at all. And in that case, your atria and the ventricles are conducting at their own rates. It's no longer synchronous. So the atria beat at their own rate, you get P waves, the ventricles beat at their own rate, and it's a really messed up rhythm, and that's complete heart block. Okay guys, so let's look at bundle branch blocks, which can be a little bit confusing, but they're not that bad when you really think about them and analyze where the wave is coming from. So we're going to start with right bundle branch block, which as the name implies is due to damage to the right bundle branch. And one thing you need to remember is that these conducting fibers of the heart are the conducting cardiomyocytes. They are cardiomyocytes, but they're specialized for conducting. They conduct much faster. The rest of your heart, the bulk of your heart, is made of contractile cardiomyocytes, which can conduct electricity. Remember, they do have to conduct the wave of depolarization, but they do it much slower. They do it through the gap junctions in the intercalated junctions in the cell, in the intercalated discs of the cardiomyocytes. So if you have damage to the right bundle branch block, you're damaging the conducting cardiomyocytes that form that pathway, and that means that electricity can still conduct through the right ventricle, but it will happen through an abnormal pathway and it will happen much slower. And as you can imagine, that would then result in a very abnormal QRS complex, both in terms of pure morphology and also in terms of the time taken, because it's going to take a lot longer. So if you think of your normal pattern of depolarization, it starts from the SA node, goes through the atria, comes through AV node. Up till this point, you're okay in a right bundle branch block. But then when you come down the bundle of His, you're supposed to split into left and right. And the right bundle branch is supposed to depolarize the right ventricle, the left is supposed to depolarize the left. And normally, because left and right contract simultaneously, that net depolarization is much, much more towards the left because the left has a much bigger muscle mass compared to the right. However, now the right bundle branch isn't conducting, so depolarization that reaches the right must have first depolarized the left and then move back to depolarize the right. So now because they're a little bit out of synchrony, you can actually see the depolarization of the right ventricle happening as a separate electrical event, not purely influenced by depolarization, not overshadowed by depolarization of the left. So what's going to happen now if you look at V1 is the electricity is going to come down and you're still going to depolarize septum from left to right. So you're still going to see your little R wave. But then instead of the wave purely moving towards the left, you now have the wave moving towards the left and you have the S wave. But then that wave that depolarized the left is going to move back towards the right and depolarize the right. So you're going to see a big additional R wave happening in V1. And you can see that because it's happening through pathways that are not the regular conducting pathways, it's much slower. So you see a much broader wave happening here. So you have the R, S, R prime, classic of right bundle branch depolarization in leads V1. And usually you see this also in lead V2. And because your depolarization pattern is totally abnormal, your repolarization pattern will also be abnormal. So you almost always will see STT abnormalities in bundle branch blocks. And if you look at lead V6, essentially you do have your normal depolarization mainly towards the left at first, so you still see the R wave, but then the wave is going to swing away and depolarize to right, so it's going to move away from V6, and you will therefore see a fairly deep S wave and a pretty broad S wave. So that is the classic pattern that you see in right bundle branch block. Similar concepts will apply in the left bundle branch block, except that now the pattern of depolarization changes a little bit more. Okay guys, so let's look at left bundle branch block, where the problem here is that you have damage to the left bundle branch. So now electricity cannot flow down this conducting pathway. So the pattern of depolarization over the ventricles will be totally different from that in right bundle branch block, and of course different from normal. So what's going to happen now is there's a change in many different aspects. You still have SA node depolarizing and coming down to the AV node, but now the septum won't be depolarizing from left to right, because those branches that depolarize the septum from left to right originated from the left bundle branch block. So now everything is coming from the right bundle branch blocks, from the right bundle branch. So that's going to go right to left. So because of that, you now don't have that normal little R wave that you normally see, and you don't have the normal little S wave. So now what you have is an immediate S wave and in V1 and an immediate R wave in V6. And that is because in general, the left ventricle is still dominant. So even though the depolarization originates from the right bundle branch block, the overall pattern of movement of the wave of depolarization is from right towards the left. So you're going to see a deep S wave in V1 and a tall R wave, but a very broad and abnormal kind of R wave in V6. And of course, because your depolarization is totally abnormal, your repolarization is also completely abnormal, which is going to lead to a lot of abnormalities in your ST complex. So you can't interpret anything about your ST segment in a left bundle branch block. And this is just a little picture kind of summarizing the big differences between your right bundle branch block and your left bundle branch block. So in V1 and V2, for right bundle branch block, you tend to have the RS R prime complex. And in V5, V6, you have a broad and deep S. Versus in the left bundle, you get a deep S in V1 and V2, and a broad and clumsy R wave in V5, V6. So those are your classical changes. And by thinking through the patterns of depolarization, you should be able to reason out why. Okay, with ectopic beats, these are just beats that happen out of sync with normal heart rhythm normally, because there is some focus outside of the SA node that is able to depolarize when the heart muscle is able to contract, but it's happening before the SA node. So if it happens above the AV node and it's within the atria, that ectopic focus would have a slightly abnormal path to the atrium, but it will still conduct down the AV node and would result in a depolarization of the ventricles. So you'd still get the depolarization of the ventricles following that same septal left to right, and then right bundle branch, left bundle branch, so you get a normal QRS morphology. But if your depolarization takes place somewhere in the ventricle, it's not coming down the normal pathway, it's going through a very weird pathway, so you're going to get an abnormal QRS morphology. That's how you're going to differentiate an atrial ectopic from a ventricular ectopic. And then you have ECG changes in myocardial infarction, which is the big one that you guys always need to learn to recognize. So again, it's really important to orient yourself to know where all those leads are looking at the heart, the origin of all those waves, and you do need to be aware of which leads are reflective of which arterial supply. Most of the time, your right coronary artery is very much the inferior part of the heart, leads 2-3 AVF. Your left anterior descending is very much anteroseptal, and your left circumflex artery looks a lot at the upper side of the heart and the lateral side of it. But there's usually a bit of an overlap of the supply between left anterior descending and circumflex. It's a little bit hard to really tease that apart. And this is the pattern of changes that you would see in somebody who's had a myocardial infarct. This is normal, but then once they've had the infarct, you see a huge high tall peak T because of hyperkalemia, and then you see the classic ST elevation in minutes to hours. It continues, but you may see the R wave getting less dominant because the muscle is beginning to be damaged, and then you will start seeing ST depressions manifesting, and gradually it turns into a T inversion in an infarct that is healing. And in months to years, you may have a somewhat normal complex, but you tend to have Q waves, which show you there's been an old infarct. Okay. So this is just a quick recap of why you get very different patterns in your ST segment depending on whether you have a full thickness infarct or a partial thickness infarct. And if you remember, a STEMI, which is a full thickness infarct, results in transmural injury, versus a block in your artery, which is not complete, will usually result in only subendocardial tissue dying and causing a non-STEMI, a non-ST elevation MI. Now, if you remember, this happens because when you have a complete block of your coronary artery, no blood gets in, whole muscle dies. If you have only part of the vessel that's blocked, blood can still get through, and the part of the cardiac muscle that is most vulnerable to ischemia is the subendocardial area, because your coronary arteries lie on the epicardium and then they move inwards towards the endocardium. So you need the highest, so the pressure drop would be greatest moving in towards the endocardium, and that would be the part that would be most vulnerable to ischemic damage if there is a lack of blood supply and lack of blood pressure. So if you have a myocardial injury, what you need to remember is that the tissue that is injured sets up something called an injury current, because that injured tissue is actually more positive with respect to the rest of the tissue. That's just a characteristic of injured tissue. Nobody is 100% sure why it happens. So current will move from non-injured tissue towards injured tissue, because that's the direction current flows. So if you have a lead over here, like V5, and current will move from epicardium to endocardium, so moving away from V5. So in the direction where it's affected, you would see an ST depression. But if you had a transmural direction, because all that current is just going to will be moving in a different sort of direction, it will move towards the lead on the whole this time, so you have an ST elevation. And this is how you actually identify your arterial territory based on the different regions of arterial supply. So we saw just now that the different arteries supply different regions of the heart, and those regions of the heart are represented by different ECG waves. So you can see from this pattern how that's going to be represented. Inferior heart represented by right coronary artery supply, 2-3 AVF. The lateral wall here is green, so you see that in 1 AVL and leads B5, B6. Then your left circumflex is, sorry, let's not look at the left circumflex. Let's look at your septal area, which is usually represented by V1 and V2, and your anterior wall, which is normally V3 and V4. So that's usually the classic representation, and you can recall those orientations of the leads from this image. And this is just reminding you of how does blood supply also supply the different conducting branches of the heart, so you can kind of see how when you have left anterior descending artery disease, you often may have a right bundle branch block or a left bundle branch block, because you can see that those are supplied by that artery. Okay, this is another image just showing you how you can divide the different arterial territories based on your ECG leads and how they are placed in the usual placement on a 12-lead ECG. Okay, so I think that's it that I wanted to try and recap for all the basics of ECG. I hope this kind of helps to put things in perspective, and if you can kind of understand this big picture and where the waves come from and how some of the most common defects that you see on the ECG as a result of underlying cardiac pathophysiology arise, then it'll be a lot easier to plug in all the fine details that you get from the big clinical skills slide. So I hope that helps, guys. Good luck. And this is just a reference that I found online that you could go to that had really, really good explanations. So if you want something to read, I'd suggest this website.